It is my pleasure to welcome you to the Federal Forum, an opportunity for you to discuss with federal partners some of their programs, ask your questions. We did have a question box at registration that remained lonely and empty. So, I do have volunteers in the room who are going to pass out index cards. If you have a question, please feel free to write it down and just hold it up, and we'll come grab it from you and bring it to the panelists. That gives them a little time to read it and digest before they answer. And we will make sure to pass those out, hold them out with questions. If you have them, I am excited to pass this off to Sandra.
Thank you, Allison. Also, seriously, I don't know how she found that picture because that's from my honeymoon in 2018. But nice research. That's a little scary, not gonna lie. That's the non-federal side of my life. But anyway, so embarrassing. Well, anyway, if you're curious, my honeymoon was in Nepal. I highly recommend that country to visit. It was really awesome. It was very chill. So if you need a chill place to go, Nepal is a good option. Okay, well, without further ado, I'm going to just hand it over to the panel here. I'll let them, I'm sure everybody in the room knows these wonderful individuals, but I will let them introduce themselves just briefly, just so you know. They're here. They're going to give you a little bit of background and some updates of federal programs, federal funding, whatever else, just to give you some updates. And also, please keep in mind what Allison said too. If you have a question, please don't be afraid. Just write it down, and then we'll collect them and we'll pass them on to the panel to answer. So I'll pass it over to Julie. Thank you.
Okay. Thank you, Sandra. Thank you. Thank you to our wonderful AV staff over the past 2 days. It's been really great. Yeah, thank you. So I'm Julie Kilman Pestana Zaharados. There are just 2 names in the program. I have 4 names. And just because the last session, I really liked that, where I'm from, I'll just take a brief moment. I was born on Wamisit land in Massachusetts. My mother's family are from the Swedish Maritimes. My father's family are Portuguese Islanders. So between where I grew up and where I'm from, lots of seafood. And then my married name is Zaharados, which is Greek, also a seafaring culture. And I am the mom to 2 girls, Susanna, who is 15, and Evangeline, who is 11. They actually brought me to this work. They were both preterm. And even though I had been working in public health for years, that experience in that time in the NICU with the other people who were there really changed me. It really made me want to do more work with birthing people, and that's what brings me here today. I've been on the CDC maternal mortality prevention team for almost 8 years. Although I am a federal employee and I'm happy to answer questions about that, it really isn't a job for me. It is a passion, the work that we do. And I know that's true of most people here in this room. So what we do is we support, for those of you who attended yesterday, we support maternal mortality review committees across the US and in territories, and we are also having conversations with tribes about starting review committees. Currently, we are supporting through the congressional appropriation, the Safe Motherhood Act, which is the same one that this Maternal Health Learning and Innovation Program is under. We are supporting 40 jurisdictions. We are about to announce 7 more. So we're really excited about all the interest. I mean, excited is a hard word to say and attached to maternal mortality. But in this work, we've heard over and over again, this is hard work, reviewing maternal deaths. Of course it is. And it's actually some of the most meaningful work that many of the folks I've met have said that they've done in their career. It is digging into these stories and understanding or attempting to understand the lives and the tragic events that led to their deaths is humbling and sobering, to say the least. But you know, what we learn from their lives to prevent future deaths from similar circumstances is really powerful. As I said, we're about to announced that we're funding a total of 47, and then we'll be forecasting a notice of funding opportunity very soon for our next 5-year cycle, and we are hoping to go national with territories and with tribes. So we are, forgive the turn of phrase, trying to make hay while the sun shines. There's a lot of money in this work right now, and we're just trying to help focus opportunities for action with good data. For many years, we didn't really understand maternal mortality in the US. We weren't collecting it in a uniform way across the states. So we are just working very hard to get good information so that you all can drive your programs locally. So thank you. I'll pass it to Kimberly.
Thank you, Julie. I have been working with Julie for 8 years, and there is so much power in sharing your background because I did not know that you had NICU stays. So there's just so much power in sharing where you're from. So thank you for offering that in this space. I want to say good morning to everyone. My name is Kimberly Sherman, and like Julie and Lee and Sandra and the rest of our team, this is a passion. This is not work. It doesn't feel like coming to work every day because we are honored to do this work. We're honored to change, to make a paradigm shift for maternal health in this space. I will share that I met Lee actually when I was pregnant. My first pregnancy was a twin pregnancy, and we met in an elevator, and I was very, very large, and he's now my boss. But the pregnancy was beautiful, and to have doula support and to have a natural delivery, and to be able to call on my grandmother, who, we were just talking about just a few years ago, home births were normal, and my grandmother had 13 children, and only the last 4 were born in hospitals. And so I remember being in labor with my twins, first time experiencing any of this, although being in this work and putting, just like our speaker said today, you're at your most vulnerable point, but you're also feeling so, so powerful. So I bring that to this work. And then also I had a baby during the pandemic. And so understanding what women went through, going to visits alone. I had a virtual doula for that birth, and it was different. So I bring heart to this work. I have a fabulous team that uplifts us collectively, because as you all know, working with clients, looking at mortality data is traumatic when you do it day in and day out. So we are, like I said, happy to be a part of this paradigm shift to change what the future of birthing looks like across the nation. So thank you all for being here. I'll pass it to my boss.
Thanks, Kim. Good morning again to all of you, and thank you for being here. My name is Lee Wilson, as I mentioned yesterday. I have not delivered any children, although my partner would say that I'm starting to look like I might be with child. Just those late night conversations about improving our bodies. Anyway, I'm very happy to be here with all of you and to experience the spirit that you all bring to the room. I was at a meeting. I was just talking earlier to someone in the audience about a meeting that I was at last week, and the working in this space, both on maternal morbidity and mortality and infant morbidity and mortality, is just such a moving place to be, and joyous, and I think revealing about the spirit or nature of the individuals who come to this work and come to it with a passion, which means the people who come to these sorts of meetings, that they're dedicated to doing it because it's good and it's right and it resonates with who they are. And that's one of the great things that I respect about the people that I work with in particular. I have been in the business of preventive health for now 36 years. I started out at the National Institutes of Health. I've roamed around most of the agencies in the department during those 36 years, working in substance abuse prevention, tobacco control, worked very closely with a number of the tribes in the southwestern United States for about 10 years. And then I think one of the most exciting and stressful assignments I had was working on the Affordable Care Act and the preventive services that go along with that and the essential health benefits, which is where I was introduced most to the deep and intensive work around maternal health, in particular the Women's Preventive Services Guidelines and what preventive services are covered by your insurance. Trying to marry that with what's included in the essential health benefits so that it is indeed paid for. So I moved to HRSA about 10 years ago. And haven't looked back. I plan to stay here until not until I go to the spirit world, but until I stop, until change occurs. So we have a great suite of programs, and as I mentioned yesterday, they have grown exponentially. I didn't think in 2019, December 2019, when I took the position as the division director, that we would have COVID and our budget would nearly double in that 4 years. It's been a tough 4 years and a growing 4 years, and I think we've put down some really good tent posts for future growth and a sustainable approach to the way that we do our work. And I know that there are many questions that you may have or should have when it comes to what we do to improve the situation for mothers and infants and families in the United States in particular. But one thing that I spend a lot of time wrestling with in my job that I'd put back onto you to be thinking about, not that there's an easy answer, is we have been very enlightened in the last few years about the impact of discrimination, disparities, inequity on the health of individuals in our society. But from the positions where we are as grantees, as practitioners, as the healthcare community and the preventive health community, what is it that we can actually do to make that change? I'm reminded of a conversation that I had with just somebody who is a bright star in this field, Harriet Washington, who wrote the book Medical Apartheid, which chronicles the differentiation in healthcare that African Americans have experienced compared to whites over time. And we had a very spirited discussion with a large group of people, and afterwards we had a debrief. And she said, you know, one of the important things to consider for all of us is, now that we understand the situation, now that we know what the problems are, where do we go from here? We can't sit idle with the knowledge that there are these disparities and think that it's going to improve unless there are changes that we make. And at the federal level, I spend time thinking about what are the specific changes that I have control or influence over. I may not be able to change racism in the United States, but I certainly may be able to change whether or not services are provided in a different way, whether they're available, and how they're presented. So I would ask each of you, especially those of you who are working directly with one of the innovation programs, what are the innovations that you can bring to the table that are systems-based invitations that are not just focusing specifically on one individual, but how do we make change that's sustainable and impacts multiple people over time? So that's my soapbox for the morning, and I will turn it over to whomever to ask questions. Sandra?
I know we've gotten a couple of questions in the box. We'll wait for those. We really want to take time and space to answer questions that you have. I'll go ahead and throw one out there while we go through the questions. But Julie Lee, since 2018, the landscape has changed dramatically. So can you talk about 2018, like where we were, how many states had a maternal mortality review committee supported by CDC, and now? And so just your thoughts on, 5 years, how's it different?
Certainly, it's very different. In 2018, none of the states were supported by CDC for their maternal mortality review efforts. In fact, they were all supported through Title V block grant HRSA work. But at that time, there was only about 20. And now we have all 50 states have maternal mortality review committees, so there's been a lot of progress. I started out just going on the road with the hope that we would gather a coalition of the willing. There were many states who were just doing this, as I said, under maternal child health dollars, and they were saying, we want apples to apples data to be able to compare. We need a data system. So CDC started building a data system and learning from the states what they needed. And so we built a data system. It's called Maria. I talked about it yesterday. We've put out some data briefs. You can find them at cdc.gov/erase-mm. And we're now up to 36 states contributing data. We will have more states in the next data brief, but actually all of the states are using it and are looking forward to sharing data that we can aggregate nationally to understand how to make change. So, yeah.
There's more. Okay. Actually, okay. I think, Julie, this one's for CDC. I think it's a pretty easy one, so I'm going to just read it off to you. Is the CDC including suicide in maternal mortality reviews?
So the states are including suicide in maternal mortality reviews. And so you might wonder, how do they do that? So when they identify deaths from death certificates and any linked birth or fetal death certificates, they review and abstract all of the circumstances surrounding that person's life and their death. And for example, in the case where the manner of death was by suicide, the committee will ask themselves if this person had not been pregnant, would they have died? And this is how they come up with a determination of whether the death was pregnancy related. So yes, suicides are included in the scope of review.
And also, I think I just want to offer this. So the federal government, we're really limited in how we can name things. And so for there's power behind erase MM. So like standing on, we really want to address this. We want to erase maternal mortality is noteworthy, being that we have so many limitations. I'll flag this question for Lee. I'm happy to answer too, but does the Division of Healthy Start and Perinatal Services include maternal mental health in discussions of maternal health? And if so, is mental health considered a part of the health? Is it considered a part of the division's work?
Excellent question, and very current. Yes, mental health is part of health. It is something that I've been committed to working on for many, many years. And in particular for this division, we have a number of programs that are focusing specifically on maternal mental health and improving mental health through a variety of different avenues. One, we have the Maternal Mental Health Hotline, which just celebrated on Mother's Day its 1-year anniversary. We've had over 16,000 conversations in that last year, and the number of callers and texters is increasing over time. And we catalog that information in a variety of different ways to identify what the issues are that are most likely to be presented by the individuals who are contacting us. If any of you are interested in seeing that information, please feel free to go to our website. It's up there, and it was actually in Laura's slides as it was presented yesterday. What I would like to say is that the hotline is also connected. We have a warm handoff to the National Suicide Prevention Hotline, and the Suicide Prevention Hotline has a warm handoff to us. So if you call either hotline and there is the need on the part of the counselor who is speaking to the individual to either have more comprehensive or more knowledgeable interaction, you go directly to the other hotline. You don't have to get out and call another number. So we're very proud of that and very pleased with that. A woman on our staff, my deputy Dawn Levinson, has really been the shepherd of that program over the last couple of years that we've been working on it. The other program that in particular we have seen grow significantly over the last few years, and the program has doubled in this year, and so we're going to be awarding new grants, is our maternal morbidity and mental health, depression, and substance abuse disorders program. They changed the name to add substance use disorders to the program in this last year. That program is a program that works with clinicians so that if a clinician is experiencing a situation where they need consultation from an expert, they can reach out to that expert immediately and get that sort of consultation. It also provides training and support. Many of you may be working with the MDRBD program here, but what it, and so you can correct me if I'm not representing it completely accurately, but what they're trying to do is encourage the use of screening brief referral and treatment in the trainings that they're providing to clinicians around the country. So we have that in a number of states, and we're looking at doubling the program in the next year. We also have a small program, as I mentioned yesterday, in fetal alcohol spectrum disorder. And then many of our other programs, the WIPSI program, the MHI program is looking at behavioral health, as well as the AIM program has a bundle on that and substance use disorder.
Sure. It's been renamed Maternal Mental Health and Substance Use Disorder, and those grants are going to be announced soon. Our fiscal year ends September 2023, so we'll be sharing what states have been funded. But the new name is Maternal Mental Health and Substance Use Disorder. The previous name for the cohort that's been funded for the past 5 years is Maternal Depression and Related Behavioral Disorders. Do you have one, or do you want me to keep going? Okay, this one I think is really relevant to a lot of folks in this audience, and it says, can you please talk to us about the application review process? And I'm
going to let Kim take
No. So I want to start off by saying that we represent programs. So we write program guidance. We listen, and we spend a lot of time talking to you guys in the field. What do the states need? What do communities need, so that we can write program guidance that's responsive to the states, that it gives you the flexibility to address the leading causes of maternal death in your state. So I want to say that first. We represent the program office. We write the guidance. Once the guidance is posted and you guys get it and you respond and send your applications in, that goes to a different office, and that's for to have a fair and objective review of all applications that come to the federal government. So I can highlight the process for you, but I want to be fully transparent and say we don't review your applications. We are here to support program and to make sure that the applications that are funded are in direct response to what we have asked the communities to do. Typically, you spend 60 or 90 days writing applications, and you submit them by the deadline. Once your application comes in, there's a first review, which is called completeness and eligibility. Is the applicant organization an eligible entity under the legislative authority? There are some legislative authorities that are only open to tribes. So if you are a 401c3, you're not going to get reviewed because you are not an eligible applicant. So we first check for completeness and eligibility. Are you an eligible entity, and is your application complete? Does it have the budget? Does it have a work plan? Are you trying to address maternal mortality and not do some other activity that is non-responsive to this grant? If you pass completeness and eligibility, your application is then sent to a field of reviewers. They are non-feds. They don't work for us. They are objective individuals who have some training or expertise in maternal health, specifically for the programs that we run, to say, does this make sense? Did the application that they've sent us in, are the activities in alignment with the notice of funding opportunity? Does the budget look okay? Do they have enough nurses to actually do what they want to do? So your application is reviewed by, we run a lot of programs, and we get a lot of applications, and so we have to have a fair and objective review of every single application so that it's read fully and scored. So on average, each application is read by 3 different individuals and scored. They are given about 30 days. It depends. It really depends on where we are in the fiscal year. But our reviewers, and I would encourage anyone in this room, if you are not a federal reviewer for grants, you should sign up. You are compensated for your time. You have expertise, and if you have time to review applications, we need you. So we want reviewers who understand what's happening in the field. Those applications are reviewed and scored, and then the entire panel comes together to talk about your application. And so the scores are shared, preliminary scores are shared, and you can see them on the screen. Maybe reviewer A gave this application a 70, reviewer B gave this application an 86, and reviewer C gave it a 65. Well, there's huge disparity in those scores. So all of the reviewers come together to say, let's talk about the work plan. Let's talk about the innovations that they want to employ. And there's discussion, and until they come to consensus, we can't move forward with that application. And so every application is scored that way. And then once the objective review meeting is complete, the program office, gets the rankings of those scores. So we are left out of that process until all the field reviewers have reviewed, scored, and then we can see who are the highest scoring applications. Program is in the room. So we are there. We are listening very closely, and we will pull the reviewers back to pages in the guidance that says, oh, well, we asked them to make sure they're working with their maternal mortality review committee. Is state X doing that, and where, to make sure that it's in alignment. So my staff is on every single review, every single application. The other thing that I want to mention is that we get so many applications in, we always run out of money. We can't fund everything that we get, and it sort of leads to another question that we received here. So the goal is to fund the highest ranking applications. And so I want to encourage you, if you are submitting applications to the federal government, that you have read that guidance closely, that you are responsive to what we are asking for, because you will lose points if you did not tell us what your maternal mortality rate is in your community, how you're going to be responsive to that. You have to answer the questions in order to get the maximum score. And because these are outside reviewers, they don't live in your community, they don't know what resources you have to paint a very clear picture.
To add to what Kimberly said, and she did a very thorough job of describing the process, when the reviewers have their discussion, they generate a set of strengths and weaknesses. And the strengths and weaknesses document is provided to us explaining why they gave the scores that they gave. And so if there are discrepancies, if there is a tie, we then are put in a situation of having to navigate whether or not there might be a question or a challenge to that particular application score in the process. Excuse me. In most cases, we don't challenge that. We would go back to the committee and say, you marked somebody down for a 70, but you didn't give any weaknesses. You need to go back and explain why that applicant didn't get the full score. So that is one part of the process. That is documented, and if you are an applicant, you should receive at the end of the process your strengths and weaknesses chart from the review process. I would also direct you to, when you look at a grant application, in the back there's the selection process that the government is going to go through. So the standard approach is to go rank order down the list. So everyone's given a score, and then they're given a number 1, 2, 3, 4, 5, all the way down to 154, which may be the number of applications that come in for a particular program. In the selection process, there is often a clause or a couple different clauses that say the federal government or HRSA reserves the right to introduce geographic diversity, organizational diversity, or some specific category of organization or entity that it feels is a priority for the funding, either because it's been called out by the legislation, or there is an interpretation of something in the legislation that we have made a judgment on. So we may say, and in one of our recent announcements we have said, we intend to fund at least one tribal entity. We intend to fund at least one rural program. We are looking at geographic diversity so that not all of the grants go to Massachusetts because they've got a lot of university writers there. So these are examples of things that we have seen over the years. So that's part of the process. And then we make our recommendation going forward. If we make a recommendation that is outside of the norm, then so we decide we're going to pick out of rank order because the tribe is number 10 and we only have funds for 8. We have to generate a memo, and that has to be cleared by our attorneys to make sure that we have followed what is allowed within the laws and within the regulations for grants management to make those awards. The process is set up in such a way that challenges to the process, there's not really an opportunity to challenge it because we have this outside review process, and because the timing of the awards usually comes down to the end of the fiscal year, that if there were a challenge, we would be in a position of not being able to spend the money, and then all of that money might potentially be lost. So the grant process is somewhat different from the contracting process, which is its own beast. And if anybody has any questions about that, you can see me in the back later on. I'm not going to bore all of you with that. But we try as best possible to be as open and transparent through the process. We encourage anyone who has any questions in the application window to generate those questions. We catalog them, record them if it takes place during a public meeting. We do not want anybody to have information that everybody can't have. So we then have an FAQ document that's posted on the website, frequently asked questions document, and that question will be posted there with what the generated responses for the public to be aware of. It is part of our responsibility to provide technical assistance to applicants, so don't feel like any question is a stupid question, okay? So I would encourage you to do that. That's it. Oh, also, yes, please remember to stay within the page number.
Please, please.
The latest, and grants management has all sorts of tricks of the trade to try to navigate this, because we all want to read the whole story. So we're pushing, oh, just leave those extra 2 pages. But, you know, someone just submitted one that was 100 pages over in one of the cycles that we just got. And what grants management has started doing is, at the end of page 60, everything is blacked out. We don't get to see it. We don't get to, you know, say, yeah, but they had a really good idea. It's just gone. So please don't. I mean, it's a waste of your time to do that. But it's also, it's unfortunate for you that we're not going to be able to see the whole story. Julie has her own tales of woe and success from CDC. Go ahead.
Yeah, actually, we got another question from the audience, but I will just say about the application process. You know, folks have said, it was due at noon and I uploaded at 12:01 and it was rejected. You know, it's better to just upload what you have by 11:59 and get it in than to try to be, you know, so anyway. We got a good frequently asked question from the audience, so I appreciate this. I'll read it. It is my understanding that CDC maternal mortality statistics do not include accidental or incidental causes of death if there is not an O code additionally on the death record. Can you speak to why this may be and whether we may be undercounting suicide and overdose deaths? So I'll say, I know this is confusing, but there are 2 parts of CDC that report on maternal mortality statistics. One is the National Center for Health Statistics. They report on a 42-day maternal mortality rate. And the National Center for Health Statistics, it's their job to summarize all-cause mortality, right? So they're not just doing maternal mortality, they're doing any kind of cause of death in the United States. So they are summarizing, right? They're giving you a snapshot. What you're getting from maternal mortality review committees is much more comprehensive. They are casting a wider net in the local context, so they are going to include the suicide and overdose deaths in their review. So the data has more of a lag. It takes longer to get that data from your state, but that data is going to be more comprehensive. It's going to include whether these suicides or overdoses, for example, were pregnancy related. So in our latest data brief from the maternal mortality review committees, mental health conditions was the leading cause of death. So that's why that data looks different than the NCHS data. And I'm sorry that it's confusing, and both from different parts of the CDC.
This next question is, are there federal efforts to look at the effects of disability on perinatal health as a health disparity population?
Thank you for the question. It is something that is top of mind for us. I will say that we can only go as far as the legislation allows. So we are bound by the legislation, the programs that we are able to create. And if under our innovation funding, that's where their flexibility is. So if a state is interested in looking at disability in connection or relatedness to perinatal care, the state maternal health innovation is the best place to do that, because we do not have direct funding to support that at this time.
I'll be honest, that is not one of the categories that we are currently looking at for attending to the issue of disparity. It has not been brought so much to my attention. Part of my reason for looking over at Julie was because there is a disabilities office looking specifically at areas where that may be an influence in health outcomes, but it's a little far afield from the work that we've been doing. Although it's interesting to hear, and I'm going to actually go back to our data branch and ask them some questions about what we're doing and what we know about disability and how that's influencing birth outcomes, both on the maternal and infant side.
I'm going to turn it back to Sandra in a moment, but I wanted to get to the question about where were we all 5 years ago, 2018. In 2018, HRSA held its first maternal mortality summit where we were able to bring thought leaders together to talk about maternal mortality. We'd never done anything like that or seen anything like that. And it was also expansive in that we were looking out. We typically, you know, as Americans look domestically, but we were able to look externally, internationally, to look at other countries that had improved maternal mortality rates. And we brought those, oh my goodness, 5 minutes? Y'all, these questions are so awesome. I'm sorry. Okay, well, 2018, we had this summit, and it allowed us to bring all of you here in this space. We've not had a national maternal health innovation symposium prior to what the NMHIS has done for us. This is the 4th one. So a lot, yes. A lot of work. The face of just even talking about maternal mortality has shifted and changed in the last 4 years. So I want to just encourage everyone, like our speakers this morning said, to continue to use your voice, to be loud, to talk about these issues, because we can do better, but it's just been such a short amount of time. So I'm so grateful for all of anyone who's received federal funding, who's doing this work at the state, and the local level, because it means so much. So much change has happened in we've just blinked and it's changed. So we're in 5 minutes. Last question, I guess.
Yeah, I mean, actually, this is a great question. Maybe you want to, I really like it, and I think it might be a good closing question. Can you share your wish list on how you would prioritize actions for women, children, and families? And I think those of you who may have attended the session that we did yesterday might already know this. My wish list would be that we would have better data to inform how to end preventable pregnancy-related deaths among disproportionately affected populations. That is a mouthful. But I think we're not going to get to meaningful change in maternal health outcomes in this country without prioritizing those who are most affected first. So for example, the leading causes of pregnancy-related death to Black women in this country are cardiovascular and coronary disease. They're not mental health conditions. So like understanding what are the leading causes of death to people in your local context and how can you use that data to drive your action and target your programs, that would be my big wish, where I think we can really make a difference in this time that we have.
I'm going to address the question from a slightly broader perspective. We have a suite of programs, and we spend a lot of time thinking about how each of them might influence change in the area where Congress has given us an opportunity. And we've looked at the data that are available, and we've spent a lot of time talking through stakeholder meetings with various organizations and with individuals, and in particular with groups that experience disparities. There's one sort of resounding call that I've heard, both, you know, from folks in the UK, from folks in Finland, folks in Brazil, and repeatedly here, is that women who are experiencing some of the greatest risks for maternal morbidity and mortality are women who often do not feel secure in their life circumstances and in their pregnancy and the resources around them to support them in that pregnancy. And so my wish in all of these puzzle pieces that we have is that we're building an environment where women are feeling, where individuals who are experiencing pregnancy, going through pregnancy, and postpartum period, that they are feeling secure, connected, and able to communicate what their wants are, what their needs are, and how they can best fulfill the relationship that they're developing there. So whether that be through nurses and midwives attending to them before prenatally, like they do in England, which would be great if we could do here in the United States. If it is the environment when they're in the delivery setting and when they're postpartum, so they could have a doula, so they feel supported in latching. And so that at the end of time, as I am told we are at, that women could feel that their role in motherhood is being supported.
And I'll just say my wish list is to remove the isolation around these topics. Women are isolated, our providers and practitioners are isolated in this work. The data is isolated. I want to come out of these silos and to be able to talk openly and publicly to change systems. So thank you for your questions. If we didn't answer them, we will respond to them and leave them at the front desk so that you can come back and get them. And we look forward to spending more time with you this afternoon. Thank you.